This is Mrs. Palmer-Quay with the first video for Unit 10 of the Cardiovascular System. In this video, I'm going to be covering the heart. I want to start with some basic information about the cardiovascular system. We talked about the blood in the last unit, and of course the cardiovascular system is what carries the blood around the body so it can do its various functions of transporting nutrients and removing waste and evening out body temperature and so forth. So in your cardiovascular system, you have the heart and the blood vessels. The heart, as you know, is the muscular pump that moves the blood. It's about the size of your fist, and the aorta, the major blood artery that carries the blood out to your body, is about the size of your thumb. So you can make a fist with your thumb sticking out and kind of have an idea about what your heart and aorta look like. Your blood vessels consist of the arteries and arterioles, capillaries, venules, and veins. And if you were to put all of those various tubes end to end, the piece of information I found said that it was approximately 62,000 miles long inside your body. And if you think about that, we've got several trillion cells inside you, and the capillaries do go by nearly every single cell. There are a few areas of the body where we don't have vascularization, but for the most part, capillaries touch all of your body's cells. So of course, there's going to be many miles of blood vessels in you. Your entire volume of blood circulates approximately once a minute, but of course the speed, the velocity of individual blood cells differs greatly between those that are being pushed out into the aorta at the very beginning of their circle and those that are sort of trickling through the capillaries. And the estimation is that the heart contracts about 2.5 billion times in the average lifespan. Your cardiovascular system has two parts. Two circuits, or sometimes called two loops, the pulmonary and the systemic circuits. So the pulmonary, hopefully you start to recognize these words. Pulmonary refers to the lungs, and then systemic covers the rest of your body systems. The whole purpose of the pulmonary circuit, of course, is to get the gas exchange happening in the lungs, where the oxygen comes into the blood, the carbon dioxide is released from the blood. So your blood has to go through the lungs so that everything gets sorted out so far as the gas carrying capacity of the blood. But then the systemic circuit covers getting the blood to the rest of your body. It doesn't do yourself any good if you pick up blood. If you pick up oxygen, you can't get it to your hungry cells. So the two parts of the circulatory system serve the purpose of facilitating the gas exchange with the outside environment where oxygen is available, and then carrying it into the rest of the body where your cells can use it. The heart is structured in a way that allows it to carry out the function of pumping blood through both the pulmonary and the systemic circuits. It is four-chambered. Two of them are part of the pulmonary circuit and two for the systemic circuit, and it's roughly cone-shaped, or sort of a upside-down triangle with a point facing off towards your left hip. The thoracic cavity is the place where you can find the heart, so it is well protected by the rib cage and the vertebral column, and roughly it sits between your second and fifth ribs, just above the diaphragm. The heart is covered by 3 layers of tissue. Just like everything else, we think we're all nicely wrapped inside our body. There's a fibrous pericardium, and I'm sure you can see again, peri meaning around, and we've got all these cardiac and cardi words having to do with the heart. So the pericardium is a dense connective tissue that connects the heart to the front of your thoracic cavity and down to the diaphragm and then to the back of the thoracic cavity and the vertebrae. It just sort of covers everything and allows your heart to stay suspended there in the middle of your chest. And then right around the heart itself, you have the parietal and visceral pericardium, which is a serous membrane. If you remember that serous membranes are like putting your fist inside a balloon, so you have 2 layers of membrane, and there's a cavity in between. The pericardial cavity is filled with some fluid. And this allows the heart to sort of hang suspended from the major blood vessels at the top of the heart, which is called the base of the heart, incidentally. But it sort of hangs from those blood vessels in your thoracic cavity so that it is free to kind of wiggle around when it beats and is allowed to have that freedom of movement so that the heart rate can increase if needed to pump out the blood at a faster rate given the activity level that you are having to be at. Inside the heart, you have a number of valves that we're going to be talking about in a minute that prevent backflow so that the blood is always flowing in the right direction. So here's a picture showing where your heart is located. You see it's basically under the breastbone. It's not exactly centered in your body, but it's awfully close. And that is why CPR works. You know, in CPR you're pushing down on your sternum right here, and you can see that by doing so you're compressing the heart between the breastbone in the front and the vertebral column in the back. As I said, the heart is sort of roughly upside down triangle, and the point of the heart is pointing towards the left hip over here. This is called the apex, and so that refers to the point of the heart. And then, as I said, this other part, which is actually it's on the top of the heart, but it's actually called the base of the heart. And this is where you have all your major blood vessels are connected. Here's just another picture trying to show the various membranes. You can see here that very fibrous pericardium that is on the very outermost part. And then we've got a cutaway view here. You've got your parietal pericardium on the outside, and then the visceral pericardium on the inside. And just like the other visceral layers of the serous membranes around body organs that we've studied so far, this is quite tight to the heart muscle. They've peeled it back a little bit over here in this section. So then down here you can see a tiny bit of the pericardial cavity, and of course there would be fluid in here, so that the heart is able to flex and vibrate within this sac that allows it to do the beating it can without having friction and anything that might impede its regular movement. So let's talk about the heart's chamber and its valves. Just take a look at this actual heart here cut very neatly in half. For one thing, notice that we've got the heart wall is very, very solid in muscle. This is, and you can see the muscle layer here. Here's your left ventricle being very, very thick. We do have a dividing septum down on this side, but this is your left ventricle. You can compare the size of this muscle wall here to what's over in your right ventricle. Your left ventricle, if you didn't already know it, is the part of the heart that's sending your blood to the rest of your body. And you can see that it is much stronger in pumping action because of the thickness of the heart muscle than the right ventricle. The various chambers we're going to look at in a diagram where it's a little bit clearer, but you've got the two entering rooms, the right atrium over here where blood enters the heart when it comes back from the body, the left atrium over here. We can see these little chordae tendineae. These are involved in the heart valves, and where the reference to your heartstrings refer to these little tiny cords, tendinous cords that are involved in holding your valves in place. And you can see sort of this slippery epithelial lining on the blood vessels here, which is something that's very important to keeping the blood flowing through your blood vessels. You want that smooth and slippery interior squamous epithelial cells, because that decreases the chances that platelets will stick to the walls and start a clotting reaction. You want the blood to be flowing smoothly through them all. So let's go on to a diagram to give you a little bit clearer picture than perhaps this actual heart. So here's a stylized drawing of the heart to make it a little bit clearer to see the various parts. We have the two chambers on the top, the right atrium and the left atrium, and the two chambers on the bottom, the right ventricle and the left ventricle. And you can see this picture makes them look fairly even in size. That's just more for diagram simplicity's sake. In reality, the right ventricle is smaller than the left ventricle, and I already mentioned that the muscle walls are much smaller on the right side of the heart. This is a very practical reason. The right side of the heart pumps the blood to the lungs through the pulmonary trunk here. This is the other name for the artery that is moving away from the heart to the lungs. Arteries are always moving away from the heart. So this is called the pulmonary trunk, this big large artery. But anyway, the right side of the heart only has to get the blood from the heart to the lungs right next door. It doesn't have to have a lot of muscular power, but the left side of the heart has got to get it flowing through the rest of the body so that the muscle wall is much thicker. So the four chambers then, two atria on the top, two ventricles on the bottom. We've got the major blood vessels here, veins carrying blood back into the heart, the superior vena cava, and coming from the the head and arms, and then the inferior vena cava bringing up the blood from the rest of the body. They both are attached here into the right atrium, so that coming down, you can see these holes where things are filling in. Blood. We'll get into how the blood moves through the heart in a minute. And then on the other side where blood is going out, here's your aorta, the major artery that's carrying your blood to the rest of your body. Branches off very early on, heading off to the brachial artery and up to your head to supply your brain with the blood that you need. The little blood vessels over here are the pulmonary veins, returning blood from the lungs, returning oxygenated blood from the lungs back over into the left atrium in order to finish the cycle. You can see these places where we've got basically doors have to be set up. This is where we see some valves. In between the right atrium and the right ventricle, we have a tricuspid valve. It has 3 little leaflets, 3 little flaps in it. Over on the other side, between the left atrium and the left ventricle, we have the mitral valve, which supposedly looks like a bishop's hat. That's where the name came from. It only has 2 flaps. And then you have another 3 compartmental valve in the other 2 major blood vessels over here, your pulmonary valve at the end of the pulmonary trunk, and then you can see over here and right next to it the aortic valve at the end of the aorta. And so these valves are there to prevent backwashing, to prevent blood once it has gone into the ventricle, so that it will not be able to go back up to the atrium. The valves will be closed. The arterial ventricle valves will close when the chambers are full below and contraction is starting. And the valves here at the end of these major blood vessels will shut when blood has flown into them, and it will prevent, there will not, any backwash pressure will not, they will not open. They stay closed when it is a high pressure system inside. This is a view for a top-down view of those same valves. So we kind of have sliced the heart, a transverse section, and we're looking down over here. We've got the open of this is, we've got some open valves here on the bottom, the mitral valve here on the left, and the tricuspid valve on the right. So you can kind of see there's 2 flaps here, 1, 2, and this side we've got 1, 2, and 3. And then on the other side we see them in the closed position. And basically you can think of these kind of like parachutes, so that they're kind of flexible and billow up from the bottom when the ventricles are filled with blood. They're pushing up against these leaflets of the valves, and the chordae tendineae, which you can kind of see just little bits of strings right here, are also connected to muscles to hold those valves, to keep them from flipping back through all the way, but to sort of keep them in this it's kind of like a parachute, sort of pulled down but full of pressure from underneath situation. And so then on the top we've got the pulmonary and the aortic valves, just looking at them in the closed position here on the left, and then in the open position on the right. They don't have the chordae tendineae the same way as you see in the heart muscle itself, but again, it's working by pressure to be open or to be closed. So as I already mentioned, we need to talk about how the blood flows through the heart. And even though the blood is not blue when it's deoxygenated, we talked about that, how the blood is a darker red as compared to a bright red when it has oxygen or does not have oxygen or does have oxygen. For convention's sake, most of these diagrams do use blue to represent the deoxygenated blood and then red to represent oxygenated blood. So blood moves in this path through the heart. It comes first from the body into the right atrium, then it moves to the right ventricle, which then sends it off to the lungs. After the lungs, the blood comes back to the left atrium, down to the left ventricle, to the body, and then eventually back again to the right atrium. So if you follow the diagrams, the arrows in these little diagrams, you can see blood coming in from the superior vena cava or the inferior vena cava to the right atrium, down to the right ventricle and out through the pulmonary trunk, heading off to whatever right or left lungs, depending upon which way it's going. It gets reoxygenated, comes back in through the pulmonary veins. Remember, anything coming back to the heart is a vein, even if it's carrying oxygenated blood, into the left atrium, down to the left ventricle, and then out to the aorta, where it heads to the rest of the body. So the aorta is supplying as I said, it heads to the rest of the body, but the heart itself needs a blood supply because the heart is a very busy muscle. It is continually beating, and so it needs to have its own blood supply that's providing the oxygen and taking away the waste products and the carbon dioxide. And so immediately after the blood enters the aorta, there are two coronary arteries that feed off, and you can just sort of see them here underneath the pulmonary trunk. We have the left coronary artery shown coming over there, and then we have a little right artery over here. And so these two arteries then branch and divide many, many times to feed all of the muscle cells to keep the heart itself very vascularized. A special kind of branching, you can see some little diagrams here, extra networking that happens within the blood vessels on the heart are called anastomosis, and this is similar to, you can kind of think it like the plexus we see in our spinal nerves, but it is a way of having some connections in between blood vessels to allow for duplicate supply or alternative pathways for blood to get to the heart muscle. It's just so important that the blood is supplied with the oxygen it needs to keep beating, that it is designed with some fail-safes and backups. If something should happen to one blood vessel, there's some alternative route for blood to get to most of the muscle. And then along with the arteries, we've got this, the same sort of situation going with the veins. And I said as mentioned earlier, there's the coronary sinus that collects all of the venous blood to send it back to the right atrium so that it can be transported to the lungs and be reoxygenated. These little flaps that you can sort of see on this diagram are on top of they actually are the outside of the atria, and they are known as auricles, just like an ear. Somebody thought they looked like ears. And they are just the outside surface of the atria that has, when this part of the heart does not have blood in it, these will depress down and wrinkle up a little bit, and then they can expand out when the atrium are filled with blood. So it's just the outermost layer of the atrium, and it's fairly flexible tissue because these chambers then can increase in size when they need to. Getting back to these coronary arteries, this left coronary artery is extremely important for an artery that you need to keep clear of any sort of internal clogging up. And we're going to talk about coronary heart disease in a minute, because it is feeding the left side of the heart. And the left side of the heart, this left ventricle here, is what is pushing blood out to the rest of the body. So if something happens to this left coronary artery or one of its little branches, then that heart muscle that is supposed to be supplied with nutrients and oxygen by that artery will not be able to get it anymore and will die. And a heart attack is when you are having the muscle cells are dying because there is no longer a blood supply coming to them. So the coronary arteries are what provide the blood to the heart, and there is a blockage in a coronary artery that leads to a heart attack. The fancy name for heart attack is a myocardial infarction. So in coronary heart disease, you've got some kind of clogging of the arteries. You can see here, we're seeing it developed. Atherosclerosis is the other name for it, or hardening of the arteries. We've got this fatty tissue, this fatty deposits that are building up. I know that you have heard about cholesterol now. The understanding is that it's not due so much to dietary cholesterol as some other food choices, trans fats, of course, being the one that has more recently been identified as a real culprit. The problem is that as this plaque, as it's called, builds up inside the blood vessels, it will then narrow the blood vessels. You don't have as good blood flow. It's not as smooth and slippery on its surface as the epithelial cells are, and so platelets are more likely to stick. And if you get a blood clot forming because platelets have started a clotting cascade in that part of the blood vessel, and actually goes as far as a blood clot, then nothing will get through, and you will have death and destruction occurring on this other side of the blood vessel. So having coronary heart disease can lead to a heart attack, and if a heart attack is severe enough, if enough coronary, or if a high enough amount of the heart tissue is compromised and dies, the result can be fatal, because then the heart does not have that active muscle to pump blood, and so the blood is not able to make it to the rest of the body, especially the brain. What is interesting is that heart attack symptoms are different for men and women, and so it is wise to recognize that sort of these classic chest pains, or perhaps a shoulder pain that we've seen on television and movies as a sign of a heart attack, is really more of a male sign. Women are much more likely to experience just general discomfort, shortness of breath, just sort of feeling off, and not have the classic symptoms of heart attack. If you have risk factors for heart attack and suspect that something is going wrong, the best place to go is to head to the emergency room right away, because every bit of delay means that some more cells in the heart could be dying, and once they are dead, they are gone. If you remember that the heart muscle is one part of your body that is amitotic, the cells do not regenerate, they do not undergo mitosis after growth has been finished, and so the only thing that your body can do to repair it is to put in scar tissue, and of course scar tissue is not going to contract. In fact, it's going to get in the way of the healthy tissue that's left that's trying to contract. So it's always wise not to fool around, even if it turns out to be a false alarm. It is much better to go into the emergency room and find out that there really is nothing going on with someone, there's not a heart attack occurring, than to delay and have more heart damage, irreversible heart damage occur. Since the heart attack leads to a dying of heart tissues, one of the things that the blood tests that they check to see if someone's having a heart attack is you're checking for elevated levels of enzymes that are used to clean up decaying and no longer alive heart cells, so that is an indicator that the body is mobilizing to kind of clean up an injury, and that is one of the things the doctors look at as a symptom of, has a heart attack occurred? Has there been some loss of heart muscle? So if you're at risk for a heart attack, not if you've already had it, I don't want to speak to that at all because I'm not a doctor, but there are several things that can be done if you have a risk of heart attack or know somebody. Certainly making changes in what you eat, how much you exercise, and if you're overweight, to lose that weight is the first line of defense. Then two more invasive mechanisms are angioplasty, which is involved putting a balloon into the occluded artery, with or without having a stent, and I have some pictures of these in a minute, or to actually have bypass surgery. So let's go to the pictures to kind of explain these things. So in angioplasty, the doctor is threading this thin catheter. You can see it coming here. It actually gets threaded up from the femoral artery, from back down in the thigh area. The femoral artery is fairly close to the surface of the body, and so doctors can go in with a thin, flexible catheter and watching on a screen imaging, they can follow the path of this catheter up the body, going backwards against the flow of the blood all the way to the heart. So on the end of the catheter there is a balloon, and so they can expand the balloon when it reaches the place where the artery has been clogged up a little bit or occluded, and often there is this metal, kind of looks like a gate, mesh tube around the outside of the balloon. That's a stent, and it is a way to hold that artery open, so that the balloon angioplasty was more of a temporary solution. It would open things up and allow the blood flow to go through the artery, but eventually the artery would then collapse down on itself again, and perhaps some more plaque would be laid out. And so the adding the stent was a way to try to keep that artery open as long as possible. In bypass surgery, there's a couple different things that can happen, but basically you're adding another pathway. It's a bypass like going around a city on the interstate. And so sometimes arteries are taken, and see here's one that has been attached to the aorta and then down to past where the blockage occurs. They show a blockage right here on the heart muscle. And so the arteries can be taken from various parts of the body. Sometimes they just reroute one that's, say, up just not that far away from this branch in the aorta, and so they would take a part of that and bring it down from an artery that would be normally going to the chest region, or perhaps one is going to be would be removed from the part of the radial artery from the arm. A piece of that would be transplanted onto the heart. Oftentimes, the veins from the legs are used, and so then those are taken and moved from the lower part of the body into the heart, again to make various connections to bypass. So the number of these little bypass connections that are made are explained in the name of it. So somebody had a triple bypass. There have been 3 new routes that have been put in by borrowing blood vessels, veins, or perhaps arteries from some other part of the person's body in a place where there's enough other workable blood vessels that they won't suffer greatly from losing one, but then putting it on the heart to get around a place where blood is not flowing anymore. This is ideally done before the blockage is completely closed. So someone has a very high percentage, it's 90% blocked. There's still a little bit of blood trickling through, but they want to get this bypass in before you have lost heart tissue. All right, so getting back to sort of the structure of the heart, let's talk a little bit about the heart muscle itself. As you've already seen, the thickness of the wall does vary depending upon which part of the heart you are in. If you remember back when we were talking about tissues, the cardiac muscle fibers are striated. They have single nuclei, unlike your skeletal muscles, and they're branching. They kind of look like a bunch of X's that, maybe sort of like chromosomes that are connected to each other and going off in different directions. And the branches, incollated discs, have gap junctions, which are really just a space for one cell to talk to another cell. The atrial muscle is separated from the ventricle muscle by what's known as a fibrous skeleton, which basically surrounds the valves and kind of divides the heart in half. And this is very important when it comes to the heartbeat itself and how the 2 sections of the heart contract. And also the muscle is arranged in this distinct fashion that allows the heart to push blood through because of how it squeezes, moving from, so far as the ventricles are concerned, moving from the apex up in the contraction. So here we have some pictures. First we've got the cells themselves up here. If you remember looking at these tissue pictures, so the intercalated discs are the junctions between cells, and there are actually little spaces in that section that cells can very easily communicate with each other. Then you have the heart muscle itself in this picture over here on the bottom left, and the heart muscle is called the myocardium. This is the big thick muscle layer, but then the inside of the heart is a layer, the squamous epithelial cells are called the endocardium, and this epithelial lining goes from the inside of the heart up into the blood vessels. It's all contiguous, one smooth inner lining all the way through the cardiovascular system. And then we have an epicardium as well, and it actually would be the same as the visceral pericardium. The very most outermost part of this layer is that 3rd layer of the pericardium. This diagram over here on the right is showing that around the atrium we have a figure 8 pattern of your muscle fibers that are involved in how these 2 chambers contract. But when it comes to the ventricles, it sort of spirals up here from the apex. And so this just allows the heart to contract in the way that it needs to push blood. Now we're moving on to talk about how the muscle contracts and how the contraction impulse is sent. So as I said, we've got two distinct muscle contraction units. The atriums contract as a unit and the ventricles contract as a unit. The impulse is carried by specialized muscle tissue so that the nervous system is involved, but not quite in the same way with the heart, that we've got some specialized muscle tissue that serves as sort of the pathways, the electrical wiring that happens inside the cell. The heart has its own pacemaker. Even though the central nervous system is involved in setting heart rate, if the heart cells are all by themselves and there are no nervous impulse, the sinoatrial node keeps it beating at about 70 to 80 beats per minute, which is a little higher than perhaps your resting heart rate would be, and we'll get to that in a minute. So the SA node, or the sinoatrial node, is your heart's natural pacemaker. And then you have the atrioventricular node, or the AV node, which then conducts the impulse through the ventricles. So the atrial node here, you can see we've got some words in here, and ventricular node, tells you where the impulse is being carried. So the SA node is high in the heart here, high in the right ventricle, and it initiates the impulse and it travels first down through all of the atrial fibers very, very quickly so that this whole unit basically contracts all together. The last stop of the impulse through the atrium is down here in the AV node, and we've got this fibrous skeleton, as I said, surrounding the valves, and so it does not allow any impulses to cross from the atrium to the ventricles, except through the AV node. So it's serving as a wall here to prevent any contractions getting through. The impulse reaches the AV node, and it is delayed a millisecond or two, which gives time for the blood to move from the atrium into the ventricles. You mean if the whole thing contracted all at the same time, the blood wouldn't go anywhere, but we want to have a pattern where things fill and then move on to the next chamber and get squeezed out and then move on to the next spot. And so you have to have this delay in between. From the AV node, then the impulses go down the central septum of the heart and then come around, carried by things called Purkinje fibers, and then trigger the contraction of the ventricles. And so we've got this pathway that goes from the top of the heart, across the atrium, down to the AV node, and then down around the ventricles. A very distinct two-step process in your heartbeat. So in the beating of the heart, we call it the cardiac cycle because it's repeating over and over again. And you see an alternation of contraction and relaxation. Contraction is called systole, and then relaxation is called diastole. You might have known those words already from blood pressure. Systolic and diastolic are the two numbers in your blood pressure. So if you listen to a heartbeat, you have the lub-dub sound that I'm sure you're very familiar with. And so these sounds are caused by what happens inside the heart as the valves are closing. So the lub is caused by the atrioventricular valves closing, which when concerning the heart's relaxation or contraction is occurred during ventricular systole or contraction of the ventricles. And then the dub comes when you have relaxation of the ventricles, where your pulmonary and aortic valves are closing. So ventricular diastole corresponds with the dub. So this diagram takes you through the process of the cardiac cycle. We're going to start over here in the bottom right-hand corner. We have to jump in somewhere. So in this case, the blood has come trickling into the atrium, and now gravity feeds at first into the ventricle. A lot of the filling of the ventricle actually happens just by gravity. And this is happening both at the right and the left-hand side of the heart at the same time. And then at the very end, or while it's filling, of course, these valves are very relaxed. They're open. They're letting the blood just trickle down. At the very end, the atrium will contract, which is the atrial systole, and the last bit of blood is forced down into the ventricles. And so then we've got a high pressure system here in the ventricle, and that's going to snap those valves shut. And so that the blood cannot backwash into the atrium. It has to go out either the pulmonary trunk or out the aorta, depending upon which valve, where you are. But it can't go until the ventricles contract. So then we have to move into ventricle systole, which happens moving this way, and this is where you hear that lub noise as the valves close shut. And so the ventricle will contract and send the blood out the whatever various blood vessels are. The valves at the end of the blood vessels are, again, to prevent backwash, and so they will open very easily, allow the blood to flow through, but it won't allow it to go back at all. And so then your atrium now is filling up with blood again, but these valves are still shut during the contraction time and waiting for the ventricles to empty. And then as we move on to ventricle relaxation or diastole, the blood then will be able to, the ventricles relax and the valves open up here, and then the blood can again start to trickle in to the point where we're down to the very last bit, and we are back over to where the atriums will need to, the various atrial contractions have to happen. And so this just goes continually around and around. First the upper part of the heart, the base of the heart, contracts, and then your ventricles contract, and it is just an alternating between high pressure and low pressure that keeps the valves opening and closing as you need them. What determines your heart rate? Well, of course, I already told you have a natural pacemaker in the SA node, so even though we already talked about how the nervous system in the medulla oblongata is involved in sending regular indicators to your heart, without the presence of that nervous system connection, your heart would still continue to contract. And the nervous system just acts to adjust that natural pace. So the parasympathetic nervous system, remember that's your rest and digest side of things, so it is involved in slowing down the heart rate, and the vagus nerve is the main nerve involved with that through the medulla oblongata. So if the paranervous system is firing, the heart rate will slow down below the natural pace that would be set by the SA node without any interference by the parasympathetic nervous system. And the amount that the vagus nerve is activated determines how much it slows down. So if it's a lot of innervation from the parasympathetic nervous system, there's a great deal of slowing. If there's just a little bit, it's a little bit of slowing. So it can adjust things. The parasympathetic nervous system is more involved in fine-tuning your heart rate. Your sympathetic nervous system, though, is the other way. It's the fight or flight, so it is involved in increasing the rate and the force of contractions, and it's not so able to fine-tune heart rate. I mean, it just increases things, basically, and then when it stops, the heart will go back to first its natural pacemaker amount and then perhaps lower depending upon how the parasympathetic nervous system is involved. Other things that affect the heart rate, your body temperature. Rising body temperature tends to increase your heart rate. You tend to have a little bit higher heart rate when you have a fever. A lowered body temperature will decrease your heart rate. Certain ions, especially potassium and calcium, will affect the heart rate or the length of the contractions or the regularity of the contractions, the overall rhythm. And then we have pressure receptors called baroreceptors in the aorta and in the carotid arteries, which work through the reflexes, again in the vagus nerve and in the glossopharyngeal nerve, to adjust the heart rate based on what's happening with your blood pressure. So again, homeostasis, you want to keep your blood pressure at sort of a constant level. If it's going up or going down, your central nervous system is going to step in with some reflexes to try to change your heart rate to send your blood pressure back to what's the normal preset value. An electrocardiogram, or an ECG, or if you use the Greek, it's EKG. So the EKG and ECG are exactly the same thing, electrocardiogram. And it's a recording of electrical changes that occur in the myocardium, the heart muscle, during the cardiac cycle. And so if we're looking at changes in electricity, we're looking at impulses moving through the heart muscle. And so we're looking at, is it being conducted from the SA node to the AV node down through the heart? Is that all working normally? The normal ECG wave has a certain pattern that I know you have seen, and it has three parts: the P wave, the QRS complex, and then the T wave. Somebody just named these things alphabetically. So if you look, here's this up, and then you've seen all this, right? The first little bump is your P wave, And so that is corresponding to when the atria are getting ready to contract. The atria is depolarizing, getting to the point of contraction. Muscle contraction is the heart muscle contraction is very, very similar to your skeletal muscle contraction so far as what happens electrically. So if you remember what we talked about before with that, how the voltage changes and then that triggers the impulse, the same sort of thing is happening in your heart. Then this QRS complex is quite a large, it's much more messy because you have the activation, the polarization, the depolarization of the ventricle, but you also have repolarization of the atria happening at the same time, and so it's not quite such a neat and tidy part of the electrocardiogram. And then in the section, the T wave, the last section is when the ventricle is getting ready to be able to transmit an impulse again. So it's in the refractory period, but you're having repolarization. So over on the right, we've got sort of this is what your standard heart rate would look like. If somebody's heart rate is faster than normal, those waves are occurring much closer together. If it's slower than normal, they're much farther apart. And then if the spacing in between the PQRS-T sections it varies, it tells you that someone is suffering from an irregular heartbeat. So they use the ECG to see just a little bit what's happening in the heart. How is the impulse being transmitted? How is the heart responding to this contraction impulse? So that covers what I wanted to say about the heart. There'll be 2 more videos for this unit. The next one will be on blood vessels.